Hello and thank you so much for joining us today for the webinar V3 Integration in Digital Workflows. We would like to thank Dr. Florin Cofar for being with us today and our sponsor for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by the doctor at the end of the presentation. Without any further delay, please help me welcome the expert himself, Florin Cofar.
So welcome to this webinar on digital dentistry. We're going to talk about workflows for natural teeth and dental implants. Actually, this is my first time with a digital audience, so it's a little bit probably strange for the first minutes, but we'll get to it fast. So, whenever we talk about digital, it's very important to understand that all the know-how comes from analog. So I will start just to show you where we are, just to show a sample case on analog, to understand where we want to get on digital. And then we're going to talk why we should do it, and then obviously how we should do it. Now, mainly I will focus on single implants in anterior area, because if we're talking about multiple implants, it's a whole different story. So take this case for example. As you can see here, we have a failing lateral. You can see also we have a little bit of volume asymmetry. Now, the aim, obviously, when we restore such a case is to be, first of all, minimally invasive, and second of all, to be as close to natural, obviously, as possible. So first, Gustavo Giordani was the surgeon in this case. The tooth was extracted. You can see the root came in two pieces. And now one of the nice things that we do when we work in an analog workflow is we can put the extracted root in an impression for the model, and we get something what we call the surgical alveolar model. Now, this is very nice because with this we can already copy the profile of the existing root, which is pretty close to what we want to get in the end with our implant restoration. Then we can place the implant, and as you can see, it's a V3 implant. And I'm going to talk a little bit about this implant. As you know, I'm mainly a restorative dentist, so I work with various surgeons, but the benefits of this implant are quite obvious. It's a benefit that comes by default because of its design. As you can see, it has a V-shaped design, so where we have the V areas, we're going to have more room for bone instead of titanium, which obviously, regardless of how you wish to perform surgeries, I see different ways, different styles, different surgeons, but in all of them you get a default improvement by using this design of an implant. This is the implant placement, more volatile, as you can see. And then obviously we proceed to impression, but the impression here, since we're talking about single implants, what we're going to do is we're going to transfer this with patent resin, and we're going to basically transfer to our surgical alveolar model. So what we're going to get is we're going to get in one model the emergence profile of the tooth and the implant position, which is very, very nice, because this is basically everything we need to get a nice abutment design. So as you can see, this is the replication of the situation in the mouth. And then obviously the standard stuff in this kind of case, soft tissue grafting, because we know we're going to have shrinkage in the tissue, bone addition, and then as provisional we can use, in such a case, we can use the crown we extracted. We can just simply adapt it to our implant and place it as a provisional. So more or less in this case, what you can see is what we can do in analog, and this is basically our protocol that we try to stick to this as close as possible whenever we're doing single implants in anterior area. When it comes to restoring, again, this is pretty basic things. Preparation, as you can see here, the healing that we had is very, very nice. So we're going to take impression, and in this case I chose to also prep the canine to simply improve the tissue. How can I improve the tissue with a veneer on the canine? Well, basically if I prep it a little bit subgingival on the mesial aspect, I can push the papilla and improve the soft tissue contour. So again, we can have a nice alveolar model. And this is the ceramic work of Edson da Silva from Sao Paulo, Brazil. So basically, this more or less is what we're doing in single implants in anterior area. This is the try-in. This is immediately after bonding. Bonded. I think the picture was taken the same day. There's CVCT of the implant. As you can see here, you can see in the middle frame the how nice the implant design leaves room for more bone. Here we can see the nice volume that we got and the final result. Now, as I said before, even though as a main goal we pursue digital, we always work both ways for two main reasons. One is not to be biased. Whenever you just go one way, you tend to be biased, and that's not something that we want, especially not in education. Second is because whatever we develop in digital, the know-how so far comes from analog. Now, let me talk a little bit about digital as a general perspective. And I will tell you a little story now. In 1982, there was an architect, Buckminster Fuller. He was an inventor, he was many things, more or less a genius. And there was a meeting happening at MIT Media Lab. And during this meeting, there was a lot of issues raised, and one of them was about photography going from film to digital. Now, Kodak at that time, people from Kodak were in the room, and actually they were some of the people that started, that were the sponsors of the MIT Media Lab. Now, when the issue was raised that photography might disappear from film, and actually Kodak at that time had 95% of the market, what happened is everybody argued back that, you know, film has more resolution, even it has more warmth, even the grain, even the noise on the film was seen as a feature. So basically the idea got discarded, and you all know what happened next. Kodak, I don't know how many times they filed for bankruptcy ever since, but they vanished because of not being able to see this step coming. As this was happening to Kodak, all the other industries were watching. For example, the music industry, the record labels were watching, thinking, oh, this can never happen to us. And then, you know, records, CDs started to disappear, and music became slowly into streaming online services. And then, obviously, the same thing happened. And as this was happening, the world was watching. But everybody was thinking this cannot happen to us. This happened to the book industry, it happened to television, it's happening now to television, even to things like taxis or hotels. And it's happening more and more. The idea is, in dentistry right now, we're in the part of the spectator now. We're watching and thinking, this cannot happen to us because we have things very much under control, because a very, let's say, operator dependent industry and so on and so forth. And for sure we have tons of arguments, and we have very good workflows in the analog, as one of them was explained before. So we have obviously reasons to keep us comfortable. But maybe just for the sake of what happened to others, we should at least question it. And now let's have an overview of what digital dentistry is today. First of all, one of the things that has changed is the way that we do consultation. Consultation in an analog way used to always be more or less the same thing. You have a visit, you have some chat with the patient, you have a consultation kit. You have some random chat, and then you basically ask the patient to open his or her mouth and start looking for problems and try to compile solutions. Now, because we cannot provide solutions in real time, especially in complex cases, because of the time required to plan, then we start taking records, and then consultation becomes less feasible because of the time you need to invest. But because of all the technology that there is today, now what we're doing is we're just taking the records. Why? Because if you have the pictures, if you have the DICOM, and if you have the STL, you have everything you need to plan a case. This is what we call the digital clone of a patient. It's basically the information that we need to gather so we can do always an interdisciplinary treatment plan. And why it replaces the classic consultation? Well, simply because if you have this, you no longer need to spend time looking inside one's mouth, because when you actually plan, even in the past, you would always plan on the records, right? So the thing is, time is important, and this is basically a simple information protocol that time-wise is actually very fast. This is the input that we need in digital dentistry, and it's a universal input. Regardless of how you want to work, you will always need these things. We're talking about CVCT and STL and photo-video records. Now, one of the benefits is obviously once you have this, cloud is no longer an issue today. You can store it very easy. We can have patients available to us on any device. Now, as a philosophy, this information, once you have it, it doesn't mean anything unless you compile it. It's just raw data. In order for it to make sense, we have to organize it. But as we process this information, we no longer need to send any physical thing. We can just send data. Also, a very nice benefit is that you can refer just this clone, not the patient. Let me give you an example. If you have, let's say, an interdisciplinary case, the patient sees you as the restorative, then you see that you need ortho, you see that you need surgery, and then what happens in real life dentistry, usually the surgeon wishes to see the patient before he commits to the surgery. Then you refer him to the surgeon, patient goes to the surgeon, surgeon usually will take different records, usually less records. Then for the orthodontist, the same story. You have to refer to the orthodontist before he can commit to giving you a solution. Orthodontist will take different records, and then we try to synchronize all of these things, and we know it doesn't work quite well unless the team has been working together for a really long time, which is not the usual case. It's just few places have this going in this way. But if we have a universal set of records, information is synchronized from the beginning. Now, as I was telling you, you see your point A is the raw data, the input, where you can just see the problems, but you cannot see the big picture. The big picture is once you compile it, you structure it somehow. One of the ways to do it is to use the DSD, for example. This for photo video is really nice. You can get a very good idea about what you want, where you want to go in terms of design. And obviously the shortcut between them is going to be the treatment plan. The difference between the classic way of thinking is the following. Imagine a patient with, let's say, a failing tooth. The problem is, in the classic way of doing things, if that patient would go to a surgeon, the surgeon would see the solution as an implant. He would go to an orthodontist, the orthodontist would try to close the space. He would go to an endo guy, the endo guy would try to save the tooth, and so on and so forth. There's a saying to this. For everybody who has a hammer, everything starts looking like a nail. It's very important when we're talking about interdisciplinary cases and especially treatment planning to try to think more like an architect rather than a dentist. We work as dentists, but we should have a, let's say, a mindset of an architect. Now, as I was telling you, all this information is synced from moment one, and there was a nice quote from Vanini I really like. He said at one point that in order for a dentist to create a simple restoration, first the restoration must be created in the dentist's mind, only then it can be reproduced by his hands. Now this makes perfect sense. However, in an interdisciplinary case, you need an interdisciplinary mind. And this is why we need to synchronize, and this is why we take universal records, and this is why we work on the same records. And this is why this way of doing things in the digital era really works. Now, after we have all this, after we have, let's say, an idea about the design, we can materialize it into a diagnostic workshop. For example, you can wax it up, you can do a digital design and 3D print it. Actually, 3D printing is what we're using most nowadays. How do we show this to the patient? We show it through, in a way of video rendering. Why I'm saying video rendering? Well, again, let me give you the example of the architect. If an architect wants to show you the the rendering of your house, you cannot walk you around in your house because the house isn't built yet. He has to show you something that hasn't been built yet. So he will show you actually renderings, which is pictures or videos of how the house will look. And this is the same of what we do. The way we do it is we're gonna film the patient before, we're gonna mock up whatever design we did, we're gonna film the patient with the mock-up, and we're gonna show the patient the two videos. This is very important to understand that this is, I think, the best way to present the treatment plan for various reasons. Why? One of them is, first of all, diagnostic workshops. Most of them are not additive ones, which means you have to go more buccal. Designs tend to be more bulky, and the only angle in which they look close to reality, or let's say good, is if you show from the front. Also, if you show in a video, patient understands that it is a rendering and not the final. Whereas if you show a mock-up in any way, using, I don't know, showing with the mirror or any other way, the patient tends to think that the mock-up is the same as the final. You can see this by the question they ask. Now the design is going to serve as a treatment guide for pretty much everything what we need to do, from tissue reduction to surgical guides. Basically, if we talk about digital in general, what it does, and this is something I heard from a friend in South Korea and I liked a lot. The digital, what it really does, it brings the hand closer to the mind. And come to think about it, for example, let's say you want to place an implant, you know exactly where you want to place it, but maybe, I don't know, you're having a bad day, you're having a bad moment, it happens to all of us, then the hand does not listen to your mind. But what guided surgery does is make sure that the hand is always aligned with the mind. And you can see in cases like this how important it is to use it. Not to mention that now it's not something that is hard to find. I mean, there's plenty of options, and of course they vary, but specifically the one that I'm showing you now, the M guide from MIS, I think it's a very simple and a very, very good option. The treatment itself, once you have this digital wireframe, it becomes a rehearsed exercise once we go in the mouth. And here you can see some of the steps of this particular treatment. You have the tissue reduction, extracting the tooth, grafting, then going to the prostate stage. I'm gonna skip this, go fast through this as we're in a time limit, and I will show this more detail later on. What I'm trying to show in this case is that there is the possibility to do things in a full digital way, finishing a case in a digital workflow and finishing with monolithic restoration, as you can see in this picture. And this is the final result, and as you can see, the team that worked in the case. Now let's talk a little bit about CAD/CAM. CAD/CAM has been around for how long? I think 30 years. I think 1 year ago, Sirona, which was the first company, celebrated like 3 decades. And when we're talking about anterior aesthetics, more or less we can say that as a majority of opinion around the world, CAD/CAM has failed when it comes to matching the, let's say, the artist, the handmade. People usually will tend to use CAD/CAM for anything else than anterior restorations. They would, even if they would go for anterior restorations, then they would either reshape, retouch, cut back and layer, basically alter the digital workflow, which at the end of the day, what benefit does it give you? Because you're just making a workflow exponentially more expensive, and then you have to correct it manually. It just doesn't make sense. So then the main question would be, why should we do it? But first, let's talk about, why it failed. As you can see, I put on the screen the very definition of CAD/CAM, and I think the answer of the failure in high-end aesthetics is on this very definition. Computer-aided design. Well, let's talk a little bit about design. What does design imply? Design implies creativity, okay? Creativity, by definition, is creating connections that haven't been created before. It means connecting the unconnected. It means asking the question that nobody asked before. This is creativity, and this is a quality a designer requires. Now, can a machine be creative? Well, obviously, the answer is no. Creativity is always the edge that we have as humans. This is a beautiful trait of humanity. So if we're trying to design using CAD/CAM, obviously it might lead into failure because of this very simple thing. Now, all of this changed for me when I met Paulo Cano in Livio a couple of years back. I think it was 3-4 years, when at some point I was, seeing Paulo Cano. For the ones who don't know about him, he's, I think, one of the best in the world when it comes to creating shape. He's an artist. He's a genius. So when I met him, I saw him working on a CAD/CAM system. So I remember that when I asked him why does he do it, the answer I still carry with me today, and is the reason why I pursued CAD/CAM ever since. What he told me is that I tried to copy nature all my life, and after 30 years I realized I cannot. Now, at first it might sound like humbleness. It is humbleness, but there's a very big truth to it. What he was trying to say is that when you're seeing, for example, when you're looking at a central, what you see is a, let's say, a line angle, no? Well, that line angle is usually, mathematically speaking, 1000 points. Now, the thing is, if you understand this simple logic, you understand that you can never truly copy using your hands and your eyes. Of course, the artists of this world will get very close to it because of a lot of years of hard work and a lot of talent, but most people will never get there. Now, let's see how we can get there. Because if you understand what I'm saying, is that aesthetics, the core of aesthetics, has always been shape. It's the same for a composite, for a veneer, for a crown, for pretty much anything. Now, shape is mathematics. Any shape you can translate into polygonal geometry. And if you look around us and we simply understand this line of thought, we are among a universal library of designs that nature provides. Texture is basically DNA in a dental signature. It's unique. Every tooth nature ever created has always been different. How amazing it is to think that in, an aesthetic ratio of a central that is always a space between 8.5 and 11, nature never repeats one time the shape and the texture. And at the end of the day, this is what we're after. We call beautiful natural because this is the attribute that we're after. We want to be as close to nature as possible. So then why not copy it? Because a machine, yes, it can never design, but what it can do is it can process that geometry and turn it into a file path and actually end up with a restoration that's very accurate in terms of geometry. So a machine, the power of the machine is to copy things, not to design them. So what we can do today, and I will show you now what we're doing on natural dentition, is you can create your own library. For example, you can scan any case, any model, whatever you want, and in this particular case, using 3Shape Ortho Analyzer, it takes just a couple of minutes to segment the individual teeth, and then using the library add-on, the Scan It library that you have in Dental Designer, you can immediately form into smile libraries. Now, these smile libraries you can use to other patients. So basically, imagine that today, having the digital clone, we scan every patient that comes in the clinic. Now, some of them don't need aesthetics. Those are the people that offer the material for the ones that do. And the ones that do obviously get from the ones that have nice aesthetics. We're just recycling natural forms. So let's take this case, for example. In this case, what we're going to do first is a diagnostic mock-up, which is like that project of architecture that you're doing before you make the house. It's showing the house before it is built. So we have the intraoral scan of the patient, and we have the photo video, and then we can align the two. We can align the picture with the scan. This is another feature of 3Shape. It's called Real View, and then the STLs that you can, individual STLs of the teeth that you have from your library, and you can create as many libraries as you want. You will position, you will 3D print it, and you will end up with a mock-up that you render to the patient. So in the first appointment, that before you start any kind of treatment, the patient will see this as being the proposition of the outcome that we can deliver. So once we have this, what we want to do is preserve this geometry from start to finish for the entire case. So then a particularity of this case, because of the we had very thin biotype and we had like a Stillman fissure there, we simply, after getting the consent of the diagnostic mock-up, again, Gustavo did a very nice graph just to thicken the biotype so we can have a nice restorative process without any unpleasant surprises. So this is just a short video. Fast forward it because it's not the main topic, but it's nice to show. This is just a preemptive measure that we did in this case. As you can see in this central here, we had a really let's say a liability that I wanted to eliminate before we go into treating the case. So then after healing, we have very nice tissue, and then we can restore. Now, also one of the nice things in this kind of workflows is the fact that we can have also a Geller model, a digitally made Geller model that is easy to produce. Again, this you can do in 3Shape, and in a classical workflow, a Geller model can take half a day to a day. So then we can design the restoration. The geometry doesn't change; it stays the same through the entire process. We're milling the same shapes, and this is the nice thing about this workflow, because there is always consistency between the mock-up and the final restoration. As you can see, this is the final ceramics in the mouth, and if you look at the morphology, it's all asymmetric, it's all natural morphology that we copied from a Smile library. So let me say this again, there is no retouching on this in this kind of workflow. So after the restoration comes out of the machine, we're not going to do anything rather than polish and stain, because the essence of it is the shape and morphology, which comes from a natural one, which means we don't have a lot to change after. This is the final of the case, and this is something that we did actually during the course with my friends Alejandro Pineda and Lawrence too. And as you can see, a before and after. And just for consistency, you can see that the mock-up and the final design are identical. It's just a different material. So this is a workflow that we developed together. It's called the raw, more or less because the aim is to preserve things as they are. So we take a shape from nature and we preserve it during the entire restorative process, from the diagnostic mock-up to the final restoration. Now, in just to go back to implants, as the question is now, how do we integrate implants in this kind of workflow? So let's take a sample case. This is a case with a missing canine. It's a congenital missing canine, and again, the workflow is the same. We have the same documentation. We have the photo video. We have the scan, and with this we can design. We can print a diagnostic design, and this all of this that I showed was printed with Formlabs, which I think is quite a nice revolution in our industry. Actually, it's not a specific printer for dental. It's just a very useful one for dental. Why? Because it's simple and because it's accessible. All the other printers are just talking about 1-2 years ago, the price was, I think, 10 times more, and we wouldn't get better results. So as you can see, even though you can see the layers from the print, you can get all the geometry there, which is very nice. You can see the nice texture and the nice shape. And the resolution of this printer, you can get up to 25 microns. But to be honest, for mock-ups we use 100 because it's more than enough. You can get very nice results like this. So again, as a workflow, we will always start with a design, as you can see here. We will render to the patient what we're trying to get. And this is a case that we actually did the surgery 2 weeks ago. So it's not yet, actually the implant is not yet integrated, but it's nice to explain the entire process. Now, in this case, the mock-up is actually the surgical guide for the tissue reduction, so we're simply going to cut around it, and then in cases where bone is not too bulky, we can perform a flapless bone surgery. This is a very nice diamond tip from CV Dentis, Brazil. The nice thing about it is that it is flat, which means you can reduce very nice in the you can reduce very nice your bone without damaging tissue or the tooth, which is different than the other diamond tips, which have a coarse surface and you get a completely different effect. And we check the biologic width, and we have a tissue reduction based on our design. Now, in terms of in terms of prep, obviously the design is gonna be the prep guide. This is again the APT technique from Galib Gurel. It's not new, it's what we've been using ever since Galib invented it. And then after we prep through, back the cord, we can see we have just minimal reduction that we need to do. Then finish the preps, very thin chamfers. We're talking about these chamfers that you can see here are basically I think like 0.2 millimeters. And then one of the nice things that we're doing in this kind of case, in order for nice alignment, because alignment is one of the big issues when we're talking about cases like this, is instead of ever getting to the point where you need to align two scans, you always make a copy of the original scan, a standard copy, delete the area that you modified, and simply rescan that area, and this will give you a very, very nice alignment. Now, again, what happens to when you go to to designing the restoration, the design is already there, because when you make a standard copy of the original design, you also make a copy of the relationship in terms of position between your original scan and your diagnostic design. So at most, what you would need to do here is just sometimes, for example, if you crown lengthen, you just need to change the sagittal to bring in the individual STLs as shapes to get a nice emergence profile, but you're never altering the shape. The shape will always be preserved through the entire workflow, as you can see here. And again, what you see different than what we were doing in analog. In an analog way, we would usually place the implant and then restore the entire case. Now, because we can control completely geometry, we're trying and we're starting to think the opposite way. Well, being able to control geometry through the entire workflow gives you huge advantage. And since that final geometry is natural, this is what we want as our main concern. So we are trying to adapt all the other procedures to support this design, including the implants. Also, as you can see in the lateral, we're planning a second soft tissue graft because the size of the defect will probably be not realistic to cover everything in one graft. So we're planning a second one there. I just prepped the lateral at the CJ for biologic reasons or for aesthetic reasons. If you look at the alignment, and then we're milling the case. This case was milled in Roland. I really like the system because basically it's an open one and it allows customizations of the milling strategies in order to get some amazing results that otherwise are impossible in closed systems. And this is the restorations as they come out of the machine. This is just stain and glaze. And as you can see, for example, in the centrals, you have literally transparent areas where the restoration thickness is, I think, 0.1 millimeters, which is very nice because one of the things that we have as a issue with CAD/CAM is that minimal thickness is more than in the analog. Well, let me tell you just this, it all depends on how you can customize your system that you work, because if you can get to this kind of very, very thin restorations. As you can see, the overall thickness of these veneers is 0.2, and it can go as much as 0.1. So we're gonna do a try-in. This is the tooth, the teeth restorations. As you can see, we still have the space for the implant. We're just doing a try-in, then we're bonding. You can see the morphology and the geometry that, as I told you, it's a natural one, so there was no any man-made design involved. And then, because the implant position is related to the final design, at this point we can simply either send the STL with the design for the implant guide, or you can scan in them out if you want to be, let's say, more safe. But more or less they should be the same, at least in this kind of workflow where geometry stays the same. And this again is M-Guide by MIS, which is, I think, one of the best systems in terms of simplicity and results that you can get, which allows us to do this case flapless. I really like, personally, I like all the cases where we can go like this, because it's a very clean way to work, very minimally invasive, and the healing is amazing. The surgery in this case was done by Eric van Doren from Belgium. So you can see the implant position and placement, and then we're planning a root-shaped graft just to give volume in the area of the canine, and after healing probably we're going to place a horizontal graft at the lateral. Now there's two ways you can do it. After you put this, you can either put a scan body and scan them. This will give you the implant position. And now let me show you some nice things that we can do using the tools that we have. So in order to get the same that we're getting in analog, meaning that alveolar, the surgical alveolar model, we can get the DICOM of the patient, and with the software for MIS you can basically extract the roots. Let me explain some basics here. The DICOM is, let's say it's made of voxel, it's a cloud. STL is a solid object. But if you just change the settings, you can make most of the bone go away, and then you can export to an STL format to get the root shapes. Why would I want to do this in this case? Well, because I have a missing tooth, and I can basically copy the root from the other side. So I can copy the canine from the other side, flip it, and I can digitally place it where my future canine would be, and then I can extract it again digitally to get the alveola, ideal alveola that I need. And then I can either export a digital scan body from the implant planning software, or I can scan the position in the mouth, because even though the precision of the guide is very high, sometimes because of the index system of the implant, you can have a problem if you want to go like in the same time with the abutment and with the crown at the time of the surgery. Well, if we have the scan body, we have the implant position, and then digitally we can create an alveola from a natural root, and this is again, like we showed in the analog way, all the information that you need to make a nice abutment design. And then at the same time of the surgery, we can place it and just make sure that it's not in occlusion. What we're doing now is basically we are placing the restoration with a missing tabletop or palatal veneer, which we're bonding after integration. And this is partial healing. We still need to see the patient at the after 4 weeks for the final period, where we're gonna probably do a second graft on the lateral. But more or less you can see how things change when we're talking about implants in this kind of digital workflow. So the thing that changed is the fact that now we have full control on geometry. If the workflow is precise, then things tend to be a little bit different. And regarding digital dentistry in general, or regarding digitalization in general, all that I can tell you is that, there's one certainty. Digitalization happens because it provides feasibility. For example, let's take, Amazon. Amazon was successful because in the past, in order to get a book, you need to, print it, make it like a product, ship to a lot of people. Having it now in a digital way, it's a file on a server that can be distributed to millions of people, scaled without extra cost. It basically, all the industry literally becomes a subdivision of information industry. And this is something that provides feasibility and scalability. And This is why the evolution happens in this way. And regarding us and digital dentistry, there's one simple rule which you have to keep in mind. Whatever will whatever can be digital will be digital. Not because I like it or because you like it or because I don't like it or you don't like it. It's because evolution is based on feasibility, on a better model. And I think this is what digital dentistry can provide. So I'd like to thank you very much for you know listening to for being at this webinar. I will still be online to answer your questions. Okay, so we have a question: is the Roland a 5-axis milling machine? Actually, the Roland that you saw here is a 4-axis milling machine. The cases that we milled with Roland, which is 4-axis wet milling machine, and the other one is VLand Xenotech Hybrid, which is a 5-axis. Second question is, how do you add the missing bone volume? If you're referring about the canine case, pretty much you just need bone to ensure that the implant is feasible to place and stable. So you just need to position your implant in a way. If you can position implant in a way that you can have stable bone, then the missing volume can be overcome by tissue, and that's it. If you don't have enough bone, then obviously you need to add bone during the process. This was not the case there. Okay. Show the scan by ways to print the model. Are there digital analogs available? There are prototypes. This is a very good question. I'm actually after this myself. There are prototypes which are being in the patent process right now, and they're very nice. So because MIS is a very fast and agile company, we expect them to be out very soon, and they're very nice, yes. So we will be able to integrate the printed model with the analog, because as you're asking, I think one of the missing links right now in the entire workflow is the digital analog. Another question is how you use the physical tooth in the first case. Which one was the first case? Oh, the analog one. Well, you just drill inside and adapt it to your abutment. That's it. It's just using the existing crown, but it's just like a provisional. You don't care, you're just drilling and adapting. That's it. When are they planned to be available? I would say 2 months, but I cannot, be 100% because I'm not an official, but 2 months is a reasonable time. What do you think about the navigation, the R2Gate navigation from Megagen? I personally haven't used it. There's been people in our team that used it. I think, it. I think it's nice, but I think it's a little bit different than what we are trying to do. CareStream, if I have experience with CareStream, no, not at this point. If I don't use CEREC now, but 3Shape, is it a better choice? Let me put it this way. Both systems are nice. The idea is it depends on what you're after. A closed system will always, like Sirona, will give you the benefit of making life easy for you. It's a very good system to start with. It's very solid. It's, provides comfort, okay? But once you want to get out, once you want to go further, you want to get better, go more, the problem is you have to wait for the company business model to evolve. And I'm not particularly good on having patience to do that. So I started exploring open systems. So Skin Concept is available on any system, is just different workflows on how to use it, which means raw is one workflow. Skin, as Master Kano does it, where he places the skins, composite skins in the mouth and then scans with Serec, this is another way. And they all work, they're just different. Depending on the systems, you have different workflows. Okay, Last Diamond, yes, I have a link. The brand is called Cividentus from Brazil. It's a Brazilian company, but the for me it's worth it to go all the way to that part of the world to get this because it just makes our life so much easier. The thing is, we can do bone reduction and take impression or scan in the same day, which is really, really nice. So just try to find Cividentus, or you can find on Facebook Tony Careon, Careon. Using in-house milling like Serec would accelerate the workflow. Yes and no. Because if you use Serec in-house, it accelerates all the part prior to milling the restorations. But the not so nice part is that after you mill, you still have to work on the restorations. The workflow that I showed here, there's no work after you mill except polish and stain. So with Sirona, much faster in the first part, but then extra lab to get the same kind of result. So it's balanced at this point. It's just a matter of how, which advantage or disadvantage you prefer, because there's no universally better system at this point. There's just preferences. For me, this is my preference at this time. Yes, I think more or less the scanner is not so, so the question is, does the 3D software get you better results? Yes, I think the software has a big input in this. Basically, you have three things in CAD/CAM. You have input, which most scanners will work fine. After input, you have the processing of information. Now here, there's a lot of systems that will lose that natural morphology in the process. There's systems which are designed to soften everything. A lot of them actually, because in the past they were designed for cutback or for frameworks, which is where they were used. So all this kind of systems will more or less destroy the natural morphology. And then there's the cam, which is very important. In a closed system, you don't have the cam. So if you don't have the cam, you depend on whatever the company feels like changing next month. You don't know. When the next update comes in a closed system, it's always can be good, can be not good, because sometimes you're just want something else and you get something completely different. It's a lottery. You lose control. For videos of patients, do you use Blackmagic cameras? Yes and no. Yes, Blackmagic is the nicest one that we have, but we don't use it all the time for, it's just a lot of space, actually. It's not more difficult or anything. It's just a huge amount of storage space. We use like 5D Mark III, which is very similar and less space. With the skin restoration being milled, where do you place the sprue as you don't want to destroy the texture morphology? Well, there's a couple of options. If you can, you place it on the cervical. You can place it, if you can place it on the proximal, because the proximal is the place where you don't destroy anything, but this implies that your restoration is thick, like a crown. If the restoration is thin and you place it on the proximal, you will have vibration and it very likely to break. So if you have a thin restoration, you will place it on the cervical because the emergence profile usually has little texture and it doesn't, it's unnoticeable as you remove it and finish it. So yes, cervical if it's thin, proximal if it's thick. Any other questions? Let me check the. Oh, here I see. What do you think of MCX5? MCX5 is a great machine. I've used it just a couple of times, but for sure it's I think it's the alternative to what I showed today. I mean the only closed system milling machine that can get similar results. By saying more work in the end with CEREC, you mean that the surface is not so good? Yes, I mean that in the past, in the CEREC, as you know, we had biocopy. Now we have biogeneric copy, which pretty much tells you that the algorithm is not longer biocopy. And we can see that also when we see on the restoration, also on the design. So the thing is, we get alterations and I don't see the added value of these alterations at all. This is why what is 3DNA database? Is database is basically the database that we build for our use. It's just patients that come in, we scan a lot of, and we make our own libraries. How much finishing does the technician have to do with the skin post milling in the margins and contacts? Margins, almost nothing. Contacts, standard, more or less. You always have to work in contacts. I mean, we haven't fine-tuned that yet to the level that you don't need to do. But it's just standard stuff. And margins, very little. I mean, the emergence profile in this particular milling machines, you don't have to do anything because the problem is you have problem with the margin when the minimal thickness is like 0.5, then you have to reduce a lot. If your minimal thickness is 0.2, you can have a smooth emergence profile from the milling machine. And contacts, again, standard. Not more, not less, the same. Okay. Can we outsource to you like a planning center? Thing is, we can help you with a case or two, but the thing is, we're a small team that's always late on our own stuff as well. So if you need help, I'd love to help you. But this is, here and there. In the long run, it's not our business model to build to go commercial on this. We're trying. Our business model is to provide the fishing rod, not the fish. We're giving you the ability to do it yourself. What software you use to place the brackets digitally? You mean for orthodontics? We don't place them digitally. We print the model, place them manually, and then transfer. The MIS Center, this MIS Center used from MGuide. Yes, there's an MIS Center in Israel and there's one in Germany. Yes, you can have anytime course in our clinic. The website is denkov.net. You can find stuff there. You're always welcome. Okay, guys, I think we're reached the end. I would like to thank you all very much again for being here today, and have a nice evening, morning, day, depending on the part of the world that you're watching. Thank you very much and hope you enjoyed. Goodbye.
We would like to thank our speaker for sharing his knowledge and expertise with us today. We would also like to thank our sponsor for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Thank you again, take care, and goodbye.